So memories that are stuck in their very raw form in the amygdala and in that emotional part of the brain can be triggered, which causes a flashback. And that's the sensation that people get when they have a flashback, is that the trauma is happening now and it's happening again, and it feels like we're back in trauma time. So we try and update that information in EMDR by moving it in a safe way and keeping us in a kind of not be too hyper aroused, where we kind of keep our amygdala in check.
This is the Thinking Mind podcast.
You're actually the first psychologist I've had on the podcast, so congratulations.
Thank you. It's a privilege.
There's lots of questions I want to ask. The question I kind of end up asking everyone at some point, or I ask some variation of the question, like, how did you decide to do the thing that you ended up doing? What's sort of driven you to that place? And obviously, clinical psychology is quite a specific vocation. What's your narrative about how you got to the place that you did?
I suppose, thinking long term, I've always been someone who is very sensitive and very empathic. So I think, given my natural tendencies and my interpersonal nature, I was always drawn to a profession of working with people. I have always wanted to be a psychologist. I think from the age of about 14 or 15. I don't know, it's just been one of those things where I've just been absolutely destined to work in mental health. I remember being probably about 14 years old and being really moved by other people's, I suppose, the fact that some people can be at a disadvantage. And I remember thinking that that was really unfair and that I had a responsibility to do something about it. So that drove me, I suppose, to study psychology for my A-levels, which I loved. And then I studied it at university. So from a studying perspective, always really found it fascinating. And I was really lucky to have volunteered for a couple of kind of mental health charities. I volunteered for a cancer care centre, which I loved. So I suppose the more experience I was gaining whilst I was studying made me realise that really a career in psychology was what I wanted to do.
Mm-hmm. So you definitely had some kind of innate interest in it. Would you say that you were interested in how people or why people behaved the way they did, or the kind of internal experiences that they had, stuff like that?
Absolutely. I suppose psychology is the study of human behaviour. I've always been interested in my own behaviour. I'm quite introspective, and I grew up in a very large family, and being one of 4 siblings, you know, sometimes you're not the forefront of the attention, sometimes you have to take a back seat. And in that role, I observed a lot of differences between myself and my siblings. So I suppose using myself and finding kind of my own behaviour quite interesting and starting to think about other people as well, I suppose that's been something that's motivated me.
And where were you in terms of your siblings? Were you youngest, middle, oldest?
I still am the second oldest. So okay. I have an older sister and 2 younger brothers.
And are any of them in the mental health field at all? My
sister's a doctor. She's a paediatrician. So we always joke about how we have a heart, I suppose. My brother works in finance, but he obviously has a heart as well, but it's just a bit of a family joke. So the 2 of us have, I suppose, been driven to work in healthcare, but my 2 younger brothers haven't, which is interesting.
And something else you mentioned is the idea of people being at a disadvantage, so inequality, problems around that. And I think it's one thing that's not, like, inequality is mentioned a lot nowadays in many different respects. And one area it's not really talked about in as much as, like, the idea of psychological flexibility, psychological mindedness, that, as with many other things, this is quite distributed quite unequally as well. So I suppose in your position as a clinical psychologist, you're in a position to give that gift to people to the extent that you can, of that awareness of their own psychology, of how their mind works and things like that.
Absolutely. I am really fortunate in that I have, through my profession, learnt a lot about myself and learned to develop psychological awareness and psychological insight. And I think, if anything, a psychologist is really privileged in being able to support other people to start developing that awareness for themselves as well. And like you say, it's not distributed evenly. Some people have got, I suppose, greater insight into their psychological makeup, into their psyche. Psychology is not for everyone, though. I know that I've had discussions with people before where it might not be the right time for psychology, but being able to provide a space where human beings can come and reflect and think about themselves in a different way. It's such a privilege to be able to observe that from a therapeutic perspective.
Are there any kind of boiled down lessons that you've learned through your own sort of development, your own introspection, that you would pass on to someone else in terms of how to develop more self-awareness?
Good question. I think the use of self is really important. Psychology is very relational. We talk a lot about the importance of therapeutic relationship. So I suppose being able to understand yourself in the context of working with another person is really important. I've benefited a lot from the use of supervision that I get, both inside my trust and also personal supervision that I receive outside of that. So I'd advocate for that, because that keeps you motivated, it keeps you learning, it makes you think about things from a different perspective. And that's being able to use yourself well in a therapeutic relationship with someone else.
Mm-hmm. And so what, maybe you can, for someone who wouldn't be aware, what kind of work do you do at the moment? What does your day-to-day look like?
So I work in 2 teams at the moment. I work in a secondary care mental health service. So that's working with individuals who have got a diagnosed mental health problem, such as depression, anxiety, or a diagnosis of post-traumatic stress disorder or complex post-traumatic stress disorder. Often some people have got a diagnosis of personality disorder. So I work in that team treating mental health problems for 3 days a week. And then my other 2 days are spent working in an addictions service. So in that role, as a psychologist as well, I provide a psychological therapy service to individuals who are struggling with mental health problems and or substance misuse. So that can be any addiction to drugs or alcohol. And I find that actually there's a really big overlap between the two. I work in a trauma-focused way. A lot of the clients that I work with have experienced at some point significant life events. Many of those are adverse life events, either in their childhood or in their adult life. So I tend to approach things from a similar perspective, despite it being across 2 different teams. So whether people are using substances to self-soothe, or they might be finding other more complicated ways or other ways of trying to manage their mental health problems, I suppose my approach is very similar across the 2.
So despite the fact that, like, on a superficial level, those seem like 2 different patient groups, what you're saying is they might have quite similar problems at core, but they're dealing with it in different ways. So in your addiction services, people might be dealing with their previous trauma with the use of alcohol and drugs to self-medicate, because after all, those substances can help in a short-term basis to make people feel better and help them cope.
Yeah.
Whereas maybe patients in the other service might cope in a very different way, and that could be self-harm or other kinds of chaotic behavior.
Yes, and it might be that trauma affects the individual in different ways as well. So we might, in one team I work with a lot of clients who may have interpersonal difficulties. So that's difficulties trusting other people or difficulties establishing boundaries in a safe and effective way. So despite the presenting problem, as it were, being different, often, as you're saying, the underlying mechanism behind that tends to be quite similar.
And in terms of trauma, because I suppose when one uses the word trauma, one typically imagines very specific, impactful life events. So something like, for example, an episode of physical abuse, sexual abuse, some kind of major life event. What do you think about the idea that trauma can be more subtle and more pervasive? Or the idea of, for example, a series of micro traumas where a person in their early life has a series of not quite so significant yet subtly undermining events, which sort of affects the psychological development.
I think it's perfectly valid. And I think from a psychological perspective, it's about making meaning for the individual who has gone through those life experiences. So what might be considered trauma for me might not necessarily be traumatic to you, for example. It's all relative to the individual. So that's why the first phase of therapy is really about getting to know the individual and asking what happened. Because subjectively, the data that we get back from individuals might be very different. So in one situation, people might report very, very significant, pervasive, kind of traumatic experience, like you've described physical abuse, sexual abuse, but neglect as well. Often I speak with clients about it not necessarily being the presence of bad stuff that happens, but what can be equally as painful for an individual is the absence of good stuff too. So again, it's just about taking an individual person-centered approach to things and understanding the person who's sitting in the room with you, what they've gone through in their life, whether that's a significant one incident trauma or it's repeated smaller kind of traumas. Like you say, it's all relative, but both are kind of equally as valid.
And that being the case, that it's relative, because obviously difficult experiences are basically a human universal. What makes the difference between a difficult experience which not only could be not harmful, but could actually catalyze someone's growth? What's the difference between a difficult experience like that and a traumatic experience? What's the essence of a traumatic experience, do you think?
Do you mean in terms of how it affects us as human beings?
I suppose because there's something to be traumatic, it's born of the relationship between the subject, between the patient and the event. Mm-hmm. But what is it that will make an experience traumatic as opposed to merely adverse or difficult, do you think? There's
probably no straightforward answer for that. It's a huge field. I suppose one thing I'm thinking about is that there's been lots of research about the role of resilience. So what makes people resilient when they experience trauma? Not everyone who experiences a traumatic event will develop a diagnosable PTSD, post-traumatic stress disorder. So there's a lot to be said about how some people can bounce back from trauma. So some things that protect people from a difficult life experience or a kind of a trauma in inverted commas are things like good social support, a good attachment, which we can talk about because that underpins a lot of trauma, and as a psychologist, we talk a lot about our core beliefs and our belief systems. So trauma can either catastrophically change someone's belief systems. So, for example, if we have a prior belief that the world is safe and something terrifying and difficult happens to us, that can shift our belief about the world being safe, where we start to believe that the world is very unsafe. Or trauma or a difficult situation or traumatic experience can also serve to exacerbate existing beliefs about the world that might be negative. So if you've experienced some childhood adversity where you start to shape beliefs about yourself and the world, i.e. the world is unsafe, and something traumatic happens in the future, then that exacerbates that belief where we can, I suppose, that reinforces the negative belief that we have about the world. So I suppose it's tricky, and again, it's individual in terms of what an individual's resilience is like pre-trauma, but also we talk about this period of watchful waiting after a traumatic incident, because not everyone develops trauma. So we don't want to over-medicalize it in some way, because like you say, a lot of people can experience adversity, but not necessarily develop complex or a post-traumatic stress disorder diagnosis.
That's an interesting point. So I find this interesting because you immediately go from something quite medical or quite psychological to something quite philosophical. So your answer touched on the idea of someone's beliefs about the world or their worldview. Mm-hmm. So what I got from what you're saying is that an event that's not merely difficult but traumatic is one that subtly undermines or shakes your worldview. Mm-hmm. So you can imagine that all of us as human beings, we have some kind of internal map of how the world is. And obviously our map is flawed because we're limited inherently. And so it sounds like that a traumatic event is one that will fundamentally mess with that worldview. So you can imagine how that could be traumatic if you were a young child, to have an event which all of a sudden overnight shifts your view, perhaps in quite a radical way, of how you think the world functions or how you think certain people function. That itself is the traumatic element rather than the event itself.
Yeah, I see what you mean. And yeah, absolutely, it can be that catastrophic shift in our belief system, and like you say, that roadmap is the thing that is the most difficult to grapple with. A lot of people that I work with think, well, I used to be okay. Things, I thought things were fine beforehand. What's going on? I don't understand. I'm feeling very anxious about things. So often it's that adjustment period that's really difficult. And that's as a result of the trauma. But like you say, it can be that catastrophic shift in someone's underlying belief systems or the architectural drawing that they have about the way that they navigate through the world that can be changed quite significantly, which is really difficult to manage.
You mentioned attachment, which I don't think I've ever discussed on this podcast, but which I'm really interested in. What is, like, for someone who has no idea, what is attachment theory? How does it connect to what we've been talking about?
So I'm not an attachment expert. And again, I think you'd probably have to do a series of podcasts purely on attachment, because it is such a big topic. But I suppose attachment in a nutshell is about how we form early relationships in our lives. So attachment theory dates back a while. And I think it was Mary Ainsworth who did a really interesting kind of psychology experiment looking at the attachment between mum and baby. As often, that is the very first attachment that we form when we're born. So by having a healthy and what we call a secure attachment to another human being, whether that's mum, dad, a grandparent, a foster parent,
a primary
caregiver, absolutely, we learn to understand ourselves in that relationship. So what I mean by that is, if I cry and ask for support, if I'm in distress as an infant and the support is given to me, I learn to internalize that care that I've received from someone. That way, the next time I'm in distress, I've learnt that I can ask for help and help is given back to me. So I might learn that I'm an important person and that my needs can be met. If for any reason something happens that interferes with the development of that attachment, so it can be parental mental health difficulties, it can be trauma, it can be kind of parental substance misuse as well, where the parent or the primary caregiver is unable to meet the needs of the child. Often what happens is there's a disruption to that primary attachment. So we talk about there being kind of different forms of that disrupted attachment, such as ambivalent or anxious attachment. But all of that to say that we understand ourselves in a very different way in relation to another human being. So we might, if, for example, there's an unpredictability in another person being able to meet our needs, that might affect us very differently than if a parent or a primary caregiver can meet our needs in a good enough way. And it's in that attachment, that first relationship that we form with other people, that we develop a view of ourselves. So we start to develop this blueprint, like we've been talking about, this roadmap. So we start to develop beliefs about ourselves, i.e., I'm worthy, I'm important. And then also beliefs about other people. So other people are helpful. Other people can meet my needs. And the world around us. So that's the third kind of belief that we develop. So the world is a safe place. So if anything happens that can disrupt the attachment that we form when we're little, we might develop a very different set of beliefs. So that might be, I'm unlovable, I'm worthless, and beliefs about other people being harmful, being a danger to us, and then the world around us possibly being unsafe. So it's through attachment that we learn to really understand ourselves. And I suppose the other thing to mention about attachment, without going on for too long, is that it forms the basis of how we, forms a template, I suppose, for other relationships in our lives. as well. But like I said, you'll probably need a whole load of other podcasts to understand it in full. Yeah.
It's very detailed, but it's very fascinating to me. So I guess the crux of what you're saying is the relationships which we form in early life will be a template for how we form relationships in general, but also how we predict relationships will be. So if we can form a secure attachment to someone when we're very young, we develop a general sense that relationships can be secure, that they can be safe, that they can be predictable.
And that it's safe to express your needs to another human being because my needs will be met by them. Yeah.
And that you have value.
Absolutely.
And that the world is more or less a safe place rather than more or less a dangerous and an unpredictable place.
Yeah.
And where you not develop that sort of secure attachment, presumably you would start to see signs of that would crop up as an adult. And perhaps in quite... Well, what I find fascinating is how quite deep psychological problems can manifest in quite almost superficial, trivial ways.
Can you give me an example?
So you imagine a man who hasn't developed particularly secure attachments is going to the cinema with his girlfriend, and his girlfriend texts him to say that she's going to be late. And this man, seemingly out of nowhere, has this completely disproportionate reaction, ends up in tears, is talking to you about it, and you think, how on earth can something relatively minor manifest in such profound emotion? And I suppose you could think of that in terms of attachment, because what could be happening is that this event is reopening a wound that was made a long time ago. Absolutely.
And I think whilst it depends on the school of thought and the therapeutic kind of approach that you take in treating kind of an interpersonal difficulty like that, I suppose you're right, something as trivial as a text message or misinterpreting a text message can actually trigger lots of kind of unconscious processes, and it can probably trigger that attachment fear of, we can hypothesize about this man possibly being abandoned or rejected. So there's something about the text message that for him that increased the threat of I'm going to be rejected or abandoned here. And that sits either within the framework of attachment, or if we look at things from a kind of a schema therapy approach, it would be about triggering the child parts of us. So attachment, vulnerable children, kind of conscious, unconscious and conscious drives, regardless of the therapeutic and psychological approach that you take, is, I suppose, fundamentally saying that, there are these very deep underlying difficulties that might be triggered from, the day-to-day activities of our lives.
Mm-hmm. What do you think about text messages in general?
In what way?
It's a slightly loaded question. I'm asking you because I think text messages make people unhappy.
Okay, elaborate.
And I think that because unlike most sort of in-person human communication, where the vast majority of the communication is actually taking place non-verbally.
Absolutely, yeah.
With sort of eye contact, body language, vocal tonality, facial expressions. Text messages obviously don't have any of that, and they just have the words. And while words can obviously communicate a lot, I think you lose so much that you lose a lot, but people don't realize you're losing a lot. So when people text each other, I think it's like the illusion of communication. And I think that leads to a lot of sort of misinterpretation. I think it leads to a lot of fights, which are ultimately aren't cleared up. So you can imagine a relationship taking place largely, let's say, even if only 20% of the communication takes place over text, you can imagine how that could build up a sort of psychological strain on the relationship.
Especially if people don't often pick up the phone and resolve difficulties kind of face-to-face, or at least being able to hear tone of voice and things like that. Yeah, absolutely. You can think about how an argument or a misinterpreted text message never really gets resolved. And depending on an individual's coping strategy for unresolved distress, hypothetically, if we push it down and don't confront it, we don't assert ourselves in communicating that this text message has upset us, if we just push it down and don't deal with it in a healthy way, then obviously that, like you're describing, that might be pent up frustration. So I agree. I think text messages can very easily be misinterpreted, whether you've got difficulty in your attachment style or not. I just feel that at the moment, with kind of society the way that it is, that's the way that we're communicating. A friend of mine said that she'd been chatting to someone who picked up the phone, and she's like, this rarely ever happens. Really surprised that people communicate on the telephone. But again, that's a generational thing as well, but you're right, it's just happening less and less.
Mm-hmm. And the problem is it allows people who like to avoid more. Absolutely.
It's just kind of feeding into that, isn't it?
Yeah. And you can see even the way relationships are formed nowadays is becoming automated, computerized with dating apps and things like that. Mm-hmm. And it's interesting. I don't have a strong view on where it's going to go, but it's certainly taking us out of our element, I think.
Absolutely. Who's to know? It's progressed so quickly already. The use of kind of social media, text messages, WhatsApp, etc. It is really hard to predict. A lot of clients talk about this exact thing. They've got difficulties communicating how they feel. And isn't that part of the problem? Or is that creating a society where it's more difficult for us to express how we feel face to face? So it's really, it is playing into the avoidance that can often be kind of maintaining mental health problems, definitely.
Getting back to your work, so obviously a lot of people practice in a specific modality, let's say. So some people are psychoanalysts, so they do psychoanalysis. Some people do cognitive behavioral therapy. Is there a specific way that you work, or is it kind of more integrated?
So as a clinical psychologist, I've been trained in multiple models, predominantly CBT trained. I trained at Edinburgh University, and they kind of advocate for CBT as the first line of the first model that you learn. And once you've got to get grips with that, you can then learn further models. So having developed skills in kind of CBT, schema-focused work, trauma-focused CBT, and EMDR, that's eye movement, desensitization, and reprocessing, I actually work in a more integrated way. Okay. So it all is based on the assessment and the formulation of the individual and their difficulties. So a formulation is obviously a joint understanding of a person's problems. And once we've got really good understanding about what that formulation is, so what's maintaining the current problems, then I suppose as a clinical psychologist, I tailor my interventions based on the formulation and based on the individual's treatment goals.
Mm-hmm. So CBT is a kind of therapy with quite a wide range of applications. Mm-hmm. It can be used for anything from like social anxiety to OCD, anxiety and depression. But you also mentioned EMDR, and as my understanding is that's quite specific for post-traumatic stress disorder, is that right?
So it was initially developed for post-traumatic stress disorder by Francine Shapiro, who very sadly died actually this year, I think last month. So it was a treatment, or it is a treatment that has been developed initially for PTSD, but what they're finding is you can apply it to lots of other things as well. So the premise of EMDR is kind of healing unprocessed memories. And it might be that an unprocessed memory is the underpinning mechanism, say, in social anxiety, if someone's been shamed. So I suppose in theory, you could go and heal that unprocessed memory to try and support someone to work on their social anxiety. I know that it's been applied to phobias as well, which is really interesting. And predominantly it's been CBT, cognitive behavior therapy, for phobias that has the best evidence-based. So EMDR is a relatively newer therapy that is continuously being examined and researched. So I'm hoping, and I'm really hopeful, that the promising results we've been getting so far for its application for PTSD will show similar positive results for other presenting problems in the field of mental health.
Okay, so just like earlier we kind of widened our definition of what trauma could be. Similarly, EMDR, although initially developed for PTSD, is widening its potential application. So even though, for example, being shamed at school in a social setting might not typically be thought of as traumatic, with this new broader understanding of trauma, it fits that EMDR might be a useful therapeutic modality for that problem.
Absolutely. And I think just on your point there, the being shamed at school or being bullied at school can be hugely traumatic for someone. You know, one of the criteria for the post-traumatic stress disorder diagnosis is the re-experiencing. So we can't predict what people might re-experience or relive, so nightmares and flashbacks. An individual could develop PTSD from having been shamed at school or having been bullied. So again, it's not about being judgmental about what is or isn't considered trauma. What's traumatic for an individual, like we were mentioning earlier, is relative. Mm-hmm. Yeah.
Do you think it still applies if... I can imagine someone having a series of traumatic events that they were too young, or perhaps the events were too strongly negative to be remembered in the conscious memory. Do you think EMDR might still be useful in that instance?
Absolutely. And the reason why is because, I suppose, if we think about a memory network, and again, I'm not a neuroscientist, I'm not a memory expert per se, but when we talk about, in layman's terms, a memory network, it's not just the verbal memory. We can have a narrative about a memory, but we also remember things like how we were feeling at the time, what we were smelling, what we were feeling, so I suppose, and what we were thinking as well. So that belief that's linked to the memory network. So even if a child is young enough to have not developed the verbal memory to make sense of a traumatic incident, the memory can still be stored in a very raw form, just missing that, like the verbal narrative that can go along with it. So we can still access memories that may be held in the body. There's a lot of research about how our body remembers trauma. So you don't necessarily have to have a firm narrative or a verbal explanation for what happened, because there's so much more to a memory network than that.
So we can widen our definition of memory as well. So we can remember things. So using that line of thinking, for example, a phobia could be a way of remembering.
You mean like an unprocessed?
Exactly.
Yeah.
Albeit a crude and unhelpful way.
I suppose, yeah, we can conceptualize it like that. And often there is... I'll need to check the research about that, but often if we trace back the original fears for, say, for example, a spider phobia, there'll probably be an index kind of small t trauma, something that has led to a huge increase in fear, which has blocked the brain from doing what it needs to do to process that memory. So yeah, absolutely, we can consider things like phobia to be kind of small t.
So in a practical sense, so I imagine typically when people imagine therapy, they imagine two people talking. Maybe one of them is lying on a couch, maybe one of them isn't.
Depends on when you're doing psychoanalysis or not.
It depends whether you're doing psychoanalysis. But for EMDR specifically, what does it look like?
So I suppose it does feel a bit different to the traditional kind of talking therapy that we would think about. As with any kind of psychological model, we always have an assessment phase. So we would obtain as much information as possible from the individual about what's kind of happened to them, what their life story is. And then together we make a bit of a treatment plan about what the EMDR processing will target. So we choose hotspots of memories, for example, that we will use as a way of targeting in our EMDR. So in an EMDR session, what typically happens is you are asked as the client to hold in mind an image of the worst part of a memory. And
so let's say I'm coming to you with a spider phobia that's linked to a specific memory about spiders. You'd ask me to hold that in my mind.
So to hold an image in your mind of the worst part of that memory. And then I ask you to think of a judgment or a belief that you make about yourself in that moment, and then what you feel, how much distress you feel, and to hold that all in mind. And then what we do is bilateral stimulation. So there's lots of different ways that we do that. Traditionally, it's with eye movements. So I would ask the client to follow my fingers for a number of sets, and that's there's lots of different kind of theories about why and how that works, and we can go on to talk about it if you're interested. But it's the bilateral stimulation that helps the client to hold the memory in mind, or to have one foot in the past of the trauma, but also to maintain attention and awareness into the present. So to have kind of one foot in the present moment as well. And as we process, as we move along with the bilateral stimulation, what happens is, the theory is that we're linking up adaptive information networks to the unprocessed raw kind of memory networks. So we're trying to link up the more adaptive information to the unprocessed raw material of the trauma.
What would be the adaptive information?
So it depends on what your belief is, I suppose. So in this situation, if you felt that you were going to die by holding this spider, an adaptive piece of information would be the fact that you didn't die.
Okay.
Right? And that you're alive now and that you're safe.
So it's an update.
It's basically updating a memory, absolutely. And so between each bilateral stimulation set, I would ask you what's coming up. So we simply notice any new thoughts or feelings or body sensations, and then we just go with that. And then what we typically do is we rate the distress. So if you were scoring 10 out of 10 of distress when you were first holding on to that memory, we process the memory until it goes down to a 0, where you feel no more distress. And then what we do after that is we install a new cognition, so a new belief that is, I'm alive, I'm safe, I didn't die, something like that, until you really firmly believed that. So in terms of the bilateral stimulation, we can either do eye movements, there's hand tapping that we can do, or even holding buzzers, one in each hand, that will buzz for a number of sets.
So they're essentially simple motor tasks that you do either with your eyes or with your hands, something like that.
Yes. And I suppose what's really interesting is some of the theory behind it. So we often, as part of my EMDR prep work, do a lot of psychoeducation with my clients. So I explain a little bit about what happens when we sleep. So I discuss rapid eye movement sleep, which is when our bodies are paralyzed but our brains are the most busy, so being very active in processing information. So in a way, by replicating that rapid eye movement when we're awake helps to facilitate that processing. So that's one of the theories about why EMDR works. But what's hugely fascinating is that we don't really know exactly how it happens and how it works.
It's
so
quite
it might
mysterious.
Absolutely. And, some people have said to me, it sounds like a bit of magic, until they give it a go and get really good results from it. So you have to really trust the process to go with it. But I've read very good papers about it. And from my clinical experience, it works very well.
It's very, aside from being mysterious, it's very counterintuitive. So you wouldn't expect that. Essentially, the crux of what I'm getting is that by getting someone to engage in one or another relatively simple motor task, such as moving their eyes, while remembering a trauma, and maybe taking in some new information, the simple motor task facilitates that happening.
So I don't think it's necessarily the simple motor tasks. So you're not moving your hands or anything. You're just kind of feeling the buzzers. So
okay.
it is your eyes. Your eyes are moving.
It's eye movement.
It's the eye movement.
Eye movement allows you, for some reason, to join your re-experience of the trauma with new, more adaptive information that can allow you to process it. Yeah.
So I suppose the another part of the big psychoeducation stuff that I do with clients before we get going with the processing is about how trauma memories are stored. So I'll talk a lot about the amygdala and how that sits within the reptile part of our brain. So that's the old brain that is our threat system, and it can become very easily activated when something very terrifying happens to us. So it will flood the body with adrenaline and cortisol and things like that. To prepare us for the fight, flight, or freeze response. The difficulty is when the amygdala is really activated, it actually prevents the hippocampus, which is the librarian of our brain, to process information. So the hippocampus doesn't assign the right information to the memory or to the information that's coming in. So it's not giving it a date or a time, or it's not giving it any contextual information.
It's like in an eternal present.
Absolutely. So it's never moved to a filing cabinet of verbally accessible memories.
Hence reliving trauma.
Exactly. So it stays stuck and unprocessed in a very raw form in the amygdala, in our emotional brain. So to give you an example, if I I'm used to eating my porridge for breakfast every day, and I know for a fact that I typically have it at 7 o'clock in the morning, and it's, every day of the week. If something scary happens to me when I'm eating my bowl of porridge, say if there's an earthquake and I think I'm going to die, that information, so the smell of the porridge that's coming in, where I am, the texture of things, all of that makes up information that comes in through the senses, isn't processed in the same way, because the hippocampus hasn't given it that contextual information. So it stays stuck there, so that the next time, say hypothetically, I smell porridge, that's information that's coming in, and it's triggering my memory that there is an unprocessed memory here that needs to be moved along. Similarly, if I'm traveling on a bus and I feel the bus kind of shake when it's kind of coming to a halt, that might remind me of the same sensations I felt when I was in the earthquake. So memories that are stuck in their very raw form in the amygdala and in that emotional part of the brain can be triggered, which causes a flashback. And that's the sensation that people get when they have a flashback, is that the trauma is happening now and it's happening again, and it feels like we're back in trauma time. So we try and update that information in EMDR by moving it in a safe way and keeping us in a kind of not be too hyper aroused, where we kind of keep our amygdala in check, if you want. And we do that by kind of maintaining dual attention. So if, for example, I'm being treated for my phobia of eating porridge, for example, or that traumatic memory, I will be following the eye movements with my eyes, or the hand movements with my eyes, and I'll be holding in mind that worst part of the memory so that I'm not overwhelmed by the fear. Because often when we relive the experience, the trigger generates the same emotional response, and then again the memory gets stuck, so it's never really updated and moved to the kind of more adaptive filing cabinet, really. So
presumably the biggest issue when doing any kind of trauma work is getting let's say the amygdala to settle down enough so that it can be processed.
Yes.
And to avoid, is there the possibility of re-traumatization when you're working with someone about their trauma?
In the way that I practice is making sure that people feel safe enough. So in terms of using a phased-based approach to treating trauma, the first phase of any kind of traumatic intervention is to ensure that people have got the skills that they need to look after themselves and to self-soothe. For some people, that might need just a couple of helpful grounding exercises and things like that. Other people might need a prolonged period of safety and stabilization before they feel ready enough to do the memory processing work. So there's a few sessions of groundwork to ensure they're capable of doing it, essentially. Yeah, I suppose it's not particularly linear, so we might do a bit of processing and then go back. So it's always kind of trying to learn the most helpful ways of managing distress in the moment. So a lot of strategies that I teach need a lot of practice during the session. So things like mindfulness, calm and soothing rhythm breathing, using grounding oils and things like that. So it's really about finding strategies that work for the individual. Because by reliving the trauma in a safe way in the therapy room, often, like you say, I don't know if it's re-traumatizing, but remembering the trauma can be hugely terrifying for people. So before we even have to put people through that, we want to make sure that they feel ready enough in themselves to have to relive the trauma in order to process it. So it does feel quite oxymoronic, that we try really hard to avoid things that are scaring us, but it's actually by confronting it that we get to overcome it. Yeah, so I don't know if you'd call that re-traumatizing, but yeah. Yeah, I suppose re-traumatizing would be an extreme if you go too far. But I think at this point it's you could call it a psychological truth that confronting things which are difficult or which that inspire fear in us actually counterintuitively act to decrease that fear. That's the basis of exposure therapy for a fear or a phobia, right? Exactly. And cognitive behavior therapy looks at the role of avoidance in maintaining mental health problems. So whether that's trauma or anxiety or depression, the more we move away from things, the more they persist. So it's actually by doing the opposite that we can overcome the difficulties that we have. And often that's something that can be quite tricky to get our head around, because avoidance is so good in the short term. But in the
Avoid,
long
like using drugs and alcohol can be avoidance, right?
Exactly. So in my addictions role, it's about understanding the particular function of the drug use or of the alcohol use. So either it's a way to self-soothe, or it's a way to, like you say, block out painful thoughts and feelings. And everyone uses substances in different ways. So again, it's about taking that non-judgmental, person-centered approach and understanding the individual in terms of where they're at and why they're using the substances that they're using within kind of a trauma framework.
When delivering therapy like EMDR, is there a specific number of sessions that's typically prescribed? Does it vary significantly from individual to individual? I would imagine it would vary, but within an NHS service, does it tend to be quite a consistent amount?
So the research says that trauma processing, the phase 2 work, can be done more quickly using EMDR than other strategies. So other
phase 2
models,
would be
the reliving, reprocessing. So doing the memory specific work. So don't know why, but the research has shown that people can heal from their traumas much quicker using EMDR than something like trauma-focused CBT or narrative exposure therapy. So realistically, you could be treated from your trauma much quicker with EMDR, but again, it completely depends on your trauma history and what you're finding difficult at the moment. I suppose one of the difficulties is working in a fraught NHS system where obviously there is high demand and low resourcing sometimes. So we are limited in what we are able to offer. So we do have set number of sessions. But I think in that situation, it's about being able to be really transparent with clients and saying, well, what work should we prioritize? I work with a lot of people who've experienced significant repeated and prolonged trauma. So that's from a very early childhood through their life course. I don't think it's possible to work on everything in 25 sessions. So it's about being really transparent and saying, we have this time, let's make the most of it. What's bothering you the most now? And then contracting with that individual about what to prioritize and what to focus the piece of work on.
How many sessions would be typically prescribed in an NHS service for EMDR?
So we are guided by the clinical kind of recommendations. So we do look at kind of the NICE guidelines and things like that. So I think it's CBT, trauma-focused CBT is about 12 to 16 sessions. I think EMDR is probably similar. I'd have to double check that. But again, it depends on the individual. And obviously there's lots of reasons why research has said that it's X number of sessions. That doesn't mean that it's going to be beneficial for everyone, if that makes sense. So the NICE guidelines are based on research that is done, and depending on the research methodology, they may have chosen to deliver EMDR in 16 sessions. So that's kind of what's advocated in the guidelines. So yeah, I suppose it depends on the individual, and it also depends on the resourcing of the service in which you're accessing support from.
How does it feel to be in the room when you're doing EMDR? Do you find that progress tends to be quite gradual, or do you have those kind of aha breakthrough moments where you feel like the trauma has been released somewhat?
I think it can be either or. I've been really moved by working with a couple of individuals who have described having these epiphany moments. And it's just such a privilege to observe. As a therapist doing EMDR, you're really non-invasive. They follow. The client is doing the hard work themselves. Their brain is working to heal itself. And it's such a pleasure to be able to observe the linking up of the adaptive information with the unprocessed kind of memory networks. So often it can be very quick. So in a number of sets, and even in one session, someone can report their distress from a 10 down to a 1 or even a 0. So it can be really quick. And what's even more remarkable is sometimes as a clinician using EMDR, the client doesn't have to talk about their traumas. You don't have to describe in detail, which is often very helpful for someone who might feel quite ashamed of what's happened to them. So it's just about holding an image in mind. I don't need to know the intricate details of that memory.
So unlike most therapy, it's quite private in a way.
It is, yeah. And there are some therapeutic models that, so for example, narrative exposure therapy or prolonged exposure, that require you to tell every single detail of the traumatic event. But with EMDR, you don't have to do that. Some people have shown a preference for being treated with EMDR over something like trauma-focused CBT or prolonged exposure because of that privacy. and sometimes shame can really get in the way of us sharing our experiences with people. So despite me not necessarily knowing 100% of the details of someone's life history, just being able to observe the transformation in them and started thinking about themselves in different ways or relating to the traumatic incident in a different way is really empowering for them, and such an honor and privilege for me to work with and to observe.
Would EMDR have been developed for war veterans specifically, or was it for PTSD in general?
So my understanding is that Francine Shapiro developed it. Well, actually, I don't know if you know this is quite an interesting story, but she was out walking and she basically discovered it because it was something that she was noticing that her eyes were doing when she was thinking about a distressing memory. And she noticed that her eyes were moving in that kind of bilateral way, and she discovered that she felt less anxious or less distressed about the things she was thinking about. So she was thinking, there's probably something in this. Let's see if we can investigate. And my sense is that she trialed it first in a veterans population, and then probably in a population who've got a diagnosis of PTSD, post-traumatic stress disorder. And from then it's been developed for lots of different kind of diagnoses.
It's weird because EMDR has this place where, despite being quite widely known how effective it is, it's not talked about very much for some reason. People talk about CBT much more, and obviously psychoanalysis is still kind of lurking in the background, and it's still quite controversial in many ways. Why do you think EMDR isn't talked about more often?
I don't know. I wish people would talk about it more.
I guess, do you think there's something about how counterintuitive it appears, how unusual?
I suppose, yes, and it does seem like a bit of a mystery, a bit of magic. And that's because, I suppose, like I was saying earlier, we, even as clinicians and those who have developed the interventions, are continuing to lead research on it. We still don't really understand the scientific rationale behind it, perhaps in the same way that we might understand the rationale behind something like CBT. So I wonder whether that's got something to do with it, or maybe it's not advertised as much. It's obviously... I suppose something I'm thinking about is that there's lots of self-help CBT options available, but there aren't many self-help EMDR options available. And CBT has been really well marketed, very well advertised. It's kind of our go-to if we think about kind of treating diagnosable mental health problems like anxiety and depression and social anxiety and things like that. So maybe it will. My hope is that more and more people will learn about EMDR, through listening to podcasts and reading about articles, and perhaps when we're working a little bit more closely with GPs to have a think about whether or not EMDR is suitable for people that they see. I remember I was working as an assistant psychologist in a specialist trauma service. This was a long time ago. And they were doing a really interesting bit of clinical audit at the time that I was working there. So they were looking back through the case files of clients on their caseload, just to track back to see how long it took for an appropriate referral to a trauma service. And they found that on average people were waiting about 7 years. So they were presenting to GP saying, I feel a bit anxious, or I'm not sleeping well. So I think we've come a long way since then, but it might be that we're not identifying trauma very well
quickly
at all.
enough.
We're not, and trauma is a really difficult thing to disclose. So if we're not being asked the right questions, how can we expect someone to give us the right answers? So my hope is that if we work more closely with GPs, and, I suppose it's about increasing everyone's knowledge of potential treatments for trauma, then hopefully EMDR will be talked about a bit more.
Mm-hmm. This might seem like a loaded question, but I'm just curious about your opinion. As someone who doesn't prescribe, what do you think about psychiatric medication?
I think it can be hugely helpful when used appropriately and for the right things. I think I see a lot of clients who are on medication and say that it's hugely helpful to kind of take the edge off their difficulties, but it doesn't solve everything. So actually that kind of partnership working between a psychologist and psychiatry is really important. So I think it has a huge role to play in terms of kind of helping people to cope a little bit better with what they're finding difficult. But some of what the research shows us is that a combination of psychology, some kind of psychological therapy, and prescribed medication can lead to the best outcomes. So there's definitely a place for it. But I wonder whether sometimes we might be over medicalizing things and overly prescribing, where actually a psychological intervention could be just as beneficial. But of course I'd say that because I'm a psychologist.
Yeah. I mean, I suppose partly it's a philosophical issue. People may disagree on the subject because of their personal predispositions. Partly it's a logistical issue, it's a systematic issue. For example, the most common place for depressed or anxious people to go nowadays in a country like England is to their GP to see them for 10 minutes. And the outcome of that consultation is frequently an antidepressant.
Yes.
And the danger there is that in such a short appointment, you would miss so much detail about what could have been causing that patient's problems, what could be perpetuating them, that you're going to miss root causes. Now, none of that is really the fault of any one particular individual. It's not the patient's fault. It's not the GP's fault.
Absolutely not.
But there's something, it seems, inbuilt into the way we deal with and think about mental health problems that's going to cause these kinds of problems. Very
possibly. But I also think it's a systemic or kind of a socially constructed difficulty as well, isn't it? Because GPs have only got so long with their appointments. They're so pressed for time and resources that actually that's the most that they can do in a situation where someone will come and say, I'm depressed or I've got anxious thoughts. Can you please help me with them? So yeah, I think it's a difficult one because from a society perspective, we've come a long way in terms of trying to reduce the stigma of mental health. So we might start to think about it differently, but I still think we've got a long way to go as well. But also I think fundamentally there's the economic kind of difficulties that we have, the social pressures, and obviously working for the NHS. I love my job. I love working for the NHS, but we all know that it's having a difficult time at the moment.
For someone who, for the sake of argument, doesn't have access to any kind of mental health care, what are the kind of things you would advise for someone to look after their own mental health to the extent that they can? Simple, kind of practical things.
The basics of eating and sleeping well. You can't minimize those. That's really important. Sleep is one of the quickest things to be affected by our mental health. So investing in our sleep, so really looking after our sleep routines, it's really important. Also getting all the nutrients that we can, getting some, obviously depends on the individual, but finding a variety of enjoyment, activities to kind of distract from the distress, keeping busy, being sociable, having time on your own as well. So finding balance, looking after ourselves, doing things like mindfulness, try and do there's good apps out there for people who aren't aware of them, things like Headspace and the app Calm I use before bed, which is really good. The internet is a good source of information as well.
Nowadays more than ever.
Absolutely. Obviously, you can't trust everything that you read, but there are some really brilliant resources out there. So kind of self-help books and really good websites that you can access.
Was trauma the subject of your PhD?
It was, yeah. So I've always been really interested in trauma. So like I said, I worked as an assistant psychologist in a specialist trauma team. So I've always known that I've wanted to go down and specialize in trauma. And that includes my doctorate research. So for my thesis, it was split into two parts. The first part was a systematic review, so looking at the existing evidence for a particular topic. So my topic was on the barriers and facilitators of children disclosing childhood sexual abuse. So what supports them in making a disclosure and what often holds them back from telling. So that was the first part of my thesis. And my second part was about the role of emotional dysregulation and interpersonal difficulties in the relationship between childhood trauma and suicidality in a cohort of Scottish men. Obviously, I studied in Edinburgh. So found some really interesting research kind of around that, and both papers have been published in the journal Child Abuse and Neglect. So I think fundamentally what came up for me was about how, particularly in the empirical research that I did, was how something like neglect, emotional neglect and emotional abuse can really shape an individual's ability to manage their emotions, and how that can also, as we were talking about earlier, affect how we relate to other people. So if trauma in some way disrupts our attachment, then we're not likely to seek support from other people when we're in distress, which predicts a higher level of suicidality, particularly in Scottish men who traditionally, I suppose, are viewed as not being able to communicate about their emotions particularly well. So there's that kind of cultural element to it as well.
So that lack of sense of security in themselves and other people means that they're less able to handle the stress.
Yeah, I suppose there's lots of different theories of suicide, but my findings kind of fit with the interpersonal theory of suicide. I think it's Joyner, who's the kind of researcher, talks about how that is a kind of, we feel like we might be burdening people by talking about our difficulties. I'm making it very simplistic. It's far more complicated than that. But I suppose the findings of my research fit within that model, that actually, having a close support network that we can pull from when we're in distress is a really strong protective factor. And if we don't have that because of our emotional dysregulation difficulties, or as a result of trauma, we're less likely to seek support, and so we might be more likely to attempt suicide as a way of coping.
Mm-hmm. What are the qualities that you think make for a good psychotherapist?
I think having an interest in other people. I'm quite a nosy person, so it's a real privilege when people share their stories with me, but not just listening. It's about bearing witness to someone's story, but being non-judgmental. It doesn't matter what someone has gone through, my response will be the same, and a good psychotherapist will be able to sit and actively listen and bear witness to someone in that space. Being able to think about things from multiple kind of perspectives is really helpful as well. Being able to reflect on the use of yourself in that therapeutic relationship. As we were talking about, it's all very relational. So a good psychological therapist will think about their own process in the therapy room as well, and use that as a way of working with the individual. And that can only be done by kind of self-exploration, going through your own therapy. I go to therapy. I'm a strong advocate for it as well, in terms of understanding myself, because that helps me with my patients.
And if you had to explain to a layperson in as concise a way as possible, what's the value of going to therapy? What do you think that would be? I'm sorry, I'm throwing you a lot of tough questions.
The value of psychological therapy. Well, I suppose it's about alleviating distress, whether that's a diagnosable mental health problem or any kind of psychological problem that we're having.
Whatever form it takes.
Whatever form it is. It's about being given the space and time to reflect and to think about ourselves in a way that we haven't possibly had the chance to do before, and to work towards making some meaningful change and to try and reduce distress and improve well-being.
Mm-hmm. It's not unlike, I suppose, it's not that different from what you would call spiritual work. We don't think about spirituality as much in modern times in the Western world. But you can imagine similar principles, introspecting, learning about yourself, alleviating distress, making meaningful change. All of those could have been outcomes from what would have typically been more referred to as a spiritual exercise maybe a few hundred years ago, or in the present day in different countries and different cultures.
Are you suggesting that psychologists are healers?
In a respect, they are, I think. I'm increasingly finding it difficult to fully delineate the difference between psychological work and spiritual work. I mean, obviously there are, I think, poles in both groups where there's a clear difference. Mm-hmm. But I think there's a significant amount of overlap as well. I mean, just the way that psychological problems so easily bleed into philosophical problems and so easily bleed into more existential problems. It can be quite hard. And I don't even think it's particularly necessary to tease them all apart, but maybe appreciate that these are just different lenses through which we can view the same problems.
Absolutely. And even, you take 5 psychologists, we all might work in a very different way as well. So absolutely, it's, it's an interesting point, probably one that I could think about and reflect on after recording.
We'll just wrap up because I'm conscious of your time. Do you have any questions that you want to ask me?
I suppose I'm always interested in why people choose psychiatry, really, and not psychology.
That's a good question. So I probably chose psychiatry. I probably ended up in psychiatry accidentally. When I was young and choosing what to do at university, I decided to do medicine because I thought it would be interesting and challenging, and I really like biology. And I wasn't as acutely aware of my interest in people and my interest in psychology. And it was only when I was maybe halfway through or towards the end of university that I realized that that's actually where my interests lied. And then at that point, it became quite obvious that psychiatry of all the medical specialties would be the one that's most appealing to me. So that's ultimately why I chose that. And even though I say it's accidental, I'm quite... I consider myself quite fortunate to have that medical background because I can start from having that kind of very, let's say, science-based way of viewing people, and then I think I can expand outwards from there in different directions, in the psychological direction, in a philosophical direction, in a spiritual direction. So I feel it's been quite valuable as a starting point.
And I suppose you've got like you say, that scientific base that perhaps a psychology trainee or a qualified clinical psychologist might not.
I suppose what I meant more to say was more of a strict medical, biological view of understanding how a person works.
More objective.
More objective, yeah. I would say more objective in a sense. I suppose the biological lens is a very specific and limited but very useful way of understanding how a person can work. That was a bit of a convoluted answer. Thank you very much for coming on the podcast.
Yeah, thanks so much for inviting me, Alex.
Thank you.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.